Dr. Hewitt, I'm going to ask you to look with me at the guidance that was available in the 1980s in relation to donor selection. Paul, can we have NHBT 0053225, please? And Dr. Hewitt, you'll see this is a version of the guidance for the selection, medical examination and care of blood donors. This version's undated. It's certainly later than 1984, but I'm not clear of the precise date. But I don't think that matters for the purposes of the questions I'm going to ask you. But was this a document that you were, whether this particular version or that you were familiar with?
Yes, very familiar, yes.
And what training was given to those running the donor sessions, so whether they're medical staff or donor attendants, about this document?
They were all provided with a copy of the document, and they were expected to be familiar with it, but I really cannot tell you what training was provided.
Now, we looked, I think, last week at the 1977 version of this. I'm not going to put it up on screen, but just for the benefit of the transcript, so it's easier for those who might want to look back at documents, that's PRSE 304358. As I say, this is probably mid-1980s or thereabouts. And I just want to look at a handful of passages and then ask you about how it might work in practice. So if we look at this on this first page at paragraph 3, we can see in capital letters, the decision whether or not a person is fit to give blood rests finally with the doctor, having due regard for the welfare of donors and the safety of recipients. And then if we go over the page, we have a section, medical examination of donors, medical history. The donor is the best judge of his or her fitness, and truthful answers to simple questions about his or her medical history and general health form a large part of the assessment. Just pausing there. Is it right to understand that, this is not a question meant in a pejorative sense, but the assumption that the blood services would have made usually is that donors who are coming as voluntary donors would be telling the truth?
Yes, that's correct. I mean, we have always relied on donors telling the truth from giving us their name and date of birth. Because
you wouldn't in the 80s would be asking for perhaps the whole range of verifying documentation that you might be asking for in terms of proving your identity nowadays, is that right? You wouldn't have said, here, can we see your passport and your driving licence and all the rest?
Certainly, when I retired from the blood service, I don't think that was in place, no.
And then we can see it says the donor session clerk should specifically question the donor about the conditions listed on form NBTS 110A and request the donor's signature on form NBTS 110. Any conditions declared should be recorded by the clerk or preferably the medical officer, most conveniently in the medical history box on the NBTS 101 donor record card or other equivalent document. So I think that second sentence confirms what you told us, I think, earlier, that there'd be a section on the 101 that would record the kind of information that might be gathered about a donor's medical history. And how well placed was the donor session clerk, who was not medically trained or not medically qualified? How well placed would they be to question a donor about these issues?
They were not. And my recollection is that the clerk, certainly I think for the sessions for which I had responsibility, the clerk would point out to the donor the conditions listed on the form and ask whether any of those applied. And if they did, then the clerk would refer the donor to the medical officer.
And then we've got a detailed list of conditions that follows. So if we look a few lines down, we've got AIDS. Action there, disqualify. So if a donor reports that they have AIDS, that's simply it. They're disqualified as a donor. There's no question of deferment or anything like that.
So just to be clear, these are conditions which might be mentioned. Well,
yes.
it's unlikely that a donor would say, I've got AIDS. But this was an A to Z for a quick reference if a donor mentioned something, that there was either an action or there was an action and there were some comments, and this was for the use of the medical officer.
So if we take perhaps a different example, anemia.
Yes.
If anemia was mentioned by the donor to the donor session clerk, we can see there it's referred to MO.
Yes.
So then the donor session clerk would refer the donor to the medical officer for the medical officer to take a decision.
Yes.
And so if we go to the next page, we can see the third line is drug abuse, action disqualify. Now, I'm going to ask you a little more about drug abuse in due course, but was it common for donors to volunteer that information?
No, not at all, not at all.
And then if we go further down the page, we'll see hepatitis. The action there is refer to MO, so refer to medical officer, and there's reference to see Appendix 1, which we'll come on to. If we go to the top of the next page, Jaundice, which is the first item, is also referred to MO. And then if we go to the next page, page 5, we've got a section of this guidance headed Notes on some of the above who require deferment. And if we look at Little Roman 4, it's got History of Hepatitis Jaundice, and then it's 12 months, but see Appendix 1 under Hepatitis. And we'll see what that means when we go over to Appendix 1 shortly. If we just then carry on to page 7, please. This is the heading Examination of the donor. Now, it refers, first of all, to haemoglobin, and I don't need to ask you about that. But then paragraph number 2, which is the third paragraph on the page, says the medical history should be coupled with a careful assessment of the donor's appearance. The experienced doctor can detect many potentially unsuitable donors at a glance, those of poor physique, the debilitated, the undernourished, the mentally unstable, and those bearing obvious stigmata of disease should not be bled. Now, first of all, the medical officer is not going to necessarily be examining every donor, are they? Or will they see every donor when they actually take the blood?
The medical officer would see every donor, because the medical officer would, first of all, look at the donor's record card. The medical officer was expected to then check the donor's identity, even though it had been done on at least 2 occasions before that. And then the medical officer would look at the donor. And one of the things, other than the things that are mentioned there, you can look at a donor's arm and see if there are any signs of any marks of needles, for instance. It's that sort of thing.
So, how realistic is it that, or how common was it that a doctor could, by reference essentially just to looking at the donor, assess their
This is a very old-fashioned document, I have to say that. But there was a concern about donors who might be underweight, purely for their own welfare, about taking a unit of blood from a donor who was under a certain weight. But the rest, in my experience, that would be so unlikely.
And then if we go on to page 10, we've got the appendix that we saw referred to earlier in the A to Z of conditions. So we've got the reference, notes on certain diseases, and then we've got AIDS. So practising homosexual and bisexual men, drug abusers, both men and women, persons from Haiti and Central Africa, particularly Zaire and Chad, haemophiliacs and the sexual contacts of all those mentioned must not be accepted as donors. We'll come on back to that when we look at the leaflets. And then the next page deals with hepatitis. It's just over a third of the way down the page. Individuals who give a history of jaundice or hepatitis or in whose blood anti-HBs is present may be accepted as donors, providing that they've not suffered from jaundice or hepatitis in the previous 12 months, have not been in close contact with hepatitis or received a transfusion of blood or blood products in the previous 6 months, and providing their blood gives a negative reaction for the presence of hepatitis B surface antigen when tested by an accepted sensitive method. Approved tests for hepatitis B surface antigen should be performed each time a donor is bled. Donors whose blood is shown to carry HBsAg shall be excluded from the ordinary donor panel. They may only be considered for reinstatement under special circumstances, and if they've been subsequently demonstrated by appropriately sensitive tests to be persistently negative for known viral markers for at least 12 months and have an adequate level of anti-HBs antibody. Can you recall how that worked in practice? If you've got a donor who has some form of previous history of hepatitis B or of jaundice, what would the and has mentioned it assumes obviously that the donor's mentioned that to the donor session clerk when they've gone through the list of conditions on form NBTS 110. It's been referred to the medical officer. What would the medical officer be expected to do?
Well, in practice, this was impossible for the medical officer at the session to carry out because they wouldn't have any knowledge of the additional tests. So this was, it was absolutely not relevant to the medical officer at the session. And this was one of the problems with this early version of the guidelines. It wasn't written for the medical officer at the session. This was including information which could only be applied afterwards. So, in fact, anybody who had a history of hepatitis or volunteered a history of hepatitis would probably be told, we can't take your blood today, but I'll refer it back to the centre for them to make a decision.
And those, obviously, those who donated the tests, that there were tests in relation to hepatitis B surface antigen that were used, have been used since the 1970s. The example given there being the RIA test. But the donors who had hepatitis or jaundice within the previous 12 months, my understanding is that the guidance was those would be deferred.
Yes.
But those who had a history of hepatitis 2 years ago, 3 years ago, 4 years ago, 5 years ago, or of jaundice, would not be deferred. Their blood would be taken, but then would only be used if the tests were satisfactory. Is that right?
As I recall it, yes.
If we leave aside for the moment any issue relating to AIDS, as at 1984 and the over the years that followed in the course of the 1980s up until around 1990, 1991, what strategies were there in relation to donor selection that might prevent donors at risk of transmitting hepatitis from donating?
Donors at risk of hepatitis?
Sorry, donors at risk of transmitting hepatitis.
Other than asking donors to volunteer a history of hepatitis, I don't recall there was. And that was a very insensitive measure because most individuals, certainly in the 1980s, who gave a history of hepatitis had hepatitis A. And most individuals who were infected with hepatitis B did not have a history of hepatitis. And most people who we subsequently found to be infected with hepatitis C also didn't have a history of hepatitis. So at the time it was thought that a history of hepatitis was significant, but it was probably much less significant than it was thought at the time.
Now, if we come then to the question of donor selection in relation to AIDS and strategies for excluding donors, when you arrived at North London Regional Transfusion Centre June 1984, there'd been a leaflet in yes. existence since September 1983. And if we just remind ourselves of that, it's BPLL 0007247. And we've looked at it on a number of occasions. We can see from the bottom it's the 1983 leaflet. And if we go to the next, we'll see top left-hand corner, will donors be questioned on sexual matters when they attend to give blood? Definitely not. I'm just pausing there. we've seen from a number of documents at the time, for example, discussions amongst regional transfusion directors, that the regional transfusion directors appear to be firmly opposed to questioning donors about sexual matters. Do you have any understanding of why that was the case? And is that something that you either agreed with at the time or looking back think was right?
I think we were living in a different age, and I think transfusion directors, in the majority, who were in place in 1980s, tended to be an older age group who would be quite anxious about that sort of questioning in respect to an individual who'd attended to volunteer to give blood. It's hard to remember now what in 1983-84 attitudes were like, but it was very different. I can't say that I would agree with that. That was as you see, that was a view that had been expressed when this leaflet was in preparation, and it was introduced in September 1983.
In practical terms, if one leaves aside what might have been a sense of trepidation at asking questions about sexual matters on the, by the regional transfusion directors, in practical terms, there would have been no impediment, would there, to actually asking the question, whether orally or in written form, have you had sex with men? Have you used the services of a prostitute? Have you used intravenous drugs ever? I mean, those kind of questions practically can easily be asked, obviously dependent upon the donor giving a truthful answer. But there's no particular reason why that couldn't have been part and parcel of the process, is there?
Absolutely not, and I think that's demonstrated by the fact that we introduced a written questionnaire for donors asking precisely that.
And we'll look at that shortly. And if we just go to the next page, we'll see that, just as a reminder, that the question, who is at risk from AIDS, in the September 1983 leaflet, describes certain groups as particularly susceptible: homosexual men who've many different partners, drug addicts, male and female, using injections, and then 3 sexual contacts of people suffering from AIDS, and then reference to those from Haiti. So just ask you to bear that in mind, because we'll come back to some of the themes that emerge in relation to those descriptions in due course. So when you arrived in June 1984, am I right in understanding that this was essentially all there was, by means of trying to discourage donations from people who were at risk of transmitting AIDS?
Well, not at North London, because we had made a couple of amendments.
Had the amendments been made at that stage? My understanding from Professor Contreras was that the printing over of homosexual men to, I think, practising homosexuals was October or thereabouts of 1984. I can check that.
She would probably know that better than I. But sorry, I didn't mean to interrupt. I believe that our call-up cards that were sent out to donors as invitations were being overprinted with a statement saying we are asking homosexuals not to donate blood. But I can't tell you when that came in.
Okay. Right. In any event, in terms of leaflets, this was the leaflet in use.
Yes.
And then it was in July of 1984, so not long after you arrived, that Professor Contreras and Dr. Barbara, after their New York visits to the New York Blood Centre, came back with the idea of the confidential unit exclusion questionnaire. And as I understand it, that was introduced initially in the West End Centre only.
That's correct. As you've heard, Professor Contreras and Dr. Barbara went to New York and saw their confidential unit exclusion questionnaire in practice, and decided it was something that we should implement at North London. They came back from New York having drafted the questionnaire on the aeroplane back, and as I recall it, presented it to me and said, we need to implement this. And we started with the West End Donor Centre because we recognised that the area that that centre covered was the highest risk area for AIDS diagnoses at that time.
Is that it covers
Geographically. So the West End Donor Centre, there will be people here who don't know where that is. It is just off Oxford Circus in central London. And so it basically covers central London and West London. So a lot of donors who worked in central London or West London or who lived in those areas donated at the West End Donor Centre.
Now, it was introduced there and then rolled out across, as I understand it, the other sessions in July of 1985.
No, sorry. I'm sorry.
Okay.
I did have a note to correct that. By July 1985, it had been implemented.
Okay,
in
so
all
by
the sessions.
rather than in.
Yes. It was started at the West End Donor Centre because we felt that that was the highest risk area. And if you like, as a pilot study to say, can we make this work? And we did. It worked and it was used. And we then introduced it at the Edgware Static Donor Clinic. And as we expected, there were far fewer positive responses because it was a very different donor population. We then extended it to the Luton Donor Clinic and then the mobile blood collection teams. But by July 1985, it was in place throughout.
And then if we just look at your witness statement, WITN 3101009, page 23. And paragraphs 54 and 55, you describe how it worked. So picking it up in the fourth line of paragraph 54, this questionnaire was given to donors in private and reinforced the message about HIV infection and self-exclusion for those at risk of infection. It also stressed that those who felt that they could not leave the session without donating, which was a recognised problem for those who attended with work colleagues or family members, should indicate on the questionnaire that their donation should not be used for patients. Just pausing there, Dr. Hewitt. Was the questionnaire then also used for by July 1984 for all the mobile sessions with employers?
So by July 1985.
And
yes. I mean, we introduced it. I can't quite remember, but we might have introduced it by team. So one team would be trained, and then whichever sessions they were doing would have the questionnaire.
Because for employees donating, it might be particularly problematic to leave without donating.
Very difficult. If you were in a work situation and the local organiser bounded up and said to a whole group of people, you know, oh, you can all come and donate blood, and one person knew they shouldn't be donating blood, then it would be exceedingly difficult for that person to sort of say, well, actually, I can't donate blood.
And then
but also, family members. I distinctly remember one young man I spoke to after he'd used the questionnaire saying, well, my mother dragged me along. How could I possibly tell her?
And then paragraph 55, all donors were informed that they could speak in confidence to the medical officer if they had any questions or concerns. In this situation, medical officers would send a confidential note back to the NLBTC medical team who would follow up any issues with the individual concerned and offer appropriate advice. So as well as the questionnaire itself, which I think the way Professor Contreras described it, there was a sort of little cubicle, a bit like when you're doing your voting in an election, and you could complete the form, no one would be able to see your answers, and then it was put in a ballot box again in the way that you would do it in an election. But additionally, the donors at North London, once the system was on operation, were told whether that they could speak confidentially to the medical officer if they wanted to raise any further or particular concerns.
And if they spoke in confidence to the medical officer would send a note back, which would be looked at by the clinical team at the centre.
And then if we could look, please, at PRSE 0003435. We've got a letter from you to Dr McClelland at SNBTS in Edinburgh, 16th of January 1985. Well, I'll just read it and then ask you about it. So, dear Brian, as promised, I'm sending you a copy of our AIDS questionnaire, explanatory note for donors and revised AIDS leaflet. This questionnaire has been in use for almost 6 months now, and this is our revised version with parts reworded in an attempt to avoid any misunderstanding on the part of donors. The completed questionnaires are returned to the RTC with the blood and are then examined to see if there are any double ticks, positive responses. These donations are removed from before any processing of the blood. Our main problem has been the lack of a questionnaire from every donor. At present, we have a member of staff in the centre putting the returned questionnaires in numerical order, and any numbers which are missing are traced. In addition, a small proportion of donors fail to tick the first box, which we cannot ignore as this implies they've not fully understood. When we contact these donors, it's almost invariable to find that they misread or misinterpreted the questions, apart from one who didn't have his reading glasses and didn't want to admit he couldn't read it. Although this is not a large problem at present, our West End Donor Centre collects only around 15% of the total donations. This could be a significant amount if extended to all our sessions, which we're seriously considering. So just pausing there, this would suggest that as at January 1985, consistent with, I think, the evidence you've already given, it's not yet universal. Although we are coping at present, we cannot extend it until we have additional staff, as there's a significant amount of extra work involved. We've only had one refusal to fill in the questionnaire, and we correctly assumed this donor was in a high-risk group. I'm also enclosing the some reasons why you should not give blood leaflet, which we devised to overcome the reluctance of the donors to pick up and read a leaflet on AIDS. Now, just pausing there, you've told us about the questionnaire previously. What was this leaflet?
I had forgotten all about this until I read this letter again. As I've said there, it was difficult for some people to be seen to be reading a leaflet which had on its cover AIDS. And especially, as I think you heard Dr. Williamson say yesterday, in communities where everybody knew each other or in workplaces, people really didn't want to be seen to be reading something about AIDS. And so we devised another leaflet, which we felt was much less, I can't think of the word, but which covered a lot more conditions or situations where people shouldn't be giving blood. If you like to give people a get-out, firstly, that they were more inclined to pick that up and read it. And secondly, it did give us some sort of ideas about what other reasons existed for not giving blood, so that people could sort of get out and not lose face. And I had forgotten all about that. And as I've said, it was very popular. It was produced within the centre, and we printed it, and we needed a lot of it, often because, unlike the AIDS leaflets, which were left at the sessions, these leaflets were taken away.
So as at January 1985, which is the date of this letter, and is obviously still some months off the introduction of screening of donations, at the North London Centre, you had the September 83 leaflet overprinted, and you would have shortly had the second version of the national leaflet. You had the questionnaire, and you had your own North London devised additional leaflet as described here.
Yeah.
And then you go on to say here, at our sessions, men are very reluctant to pick up the AIDS leaflet, but the new ones prove very popular. We're printing hundreds each week as they're taken away by the donors. Our other recent change has been to overprint our call-up cards. So here's a contemporaneous reference to what you mentioned a few minutes ago, with we are asking homosexuals not to donate. We've had one or two protests, but a generally favourable response. So it does appear from this that at North London, you've anticipated by some months the change in terminology in the national leaflets, because we've looked at the text of the national leaflet from September 1983. We know the second national leaflet, introduced a couple of weeks after this, uses the phrase practising homosexuals. And it's not until, I think, the third national leaflet in the autumn of 1985 that the national leaflet just talks about homosexuals, bisexuals. In North London, you've essentially anticipated that by using simply the phrase homosexuals and asking people not to donate. Can you recall why it was you were sending this to Dr. McClelland?
I can only assume that we'd been at a meeting together and he'd expressed an interest in seeing what we were doing.
And then if we just go to the next page, we can see a document which says, it looks like it's a fourth document that might have been given to donors. Dear donor, because of the current concern about the disease AIDS, which can be transmitted by blood products, we're asking all our donors at each attendance to complete the enclosed questionnaire. So this would accompany the questionnaire, it looks. In order to try and reduce this risk to a minimum, after booking in, would you please, 1, read the AIDS leaflet, 2, enter the side room on the left as you approach the main clinic, 1 donor at a time. Now, is that describing the setup at the West End clinic?
It's the West End Donor Centre, yes.
3, complete your questionnaire in confidence. 4, post it in the special box provided. 5, take a seat outside ready to enter the main clinic and donate. Thank you for your cooperation. And then if we go over the page, am I right in understanding that this is the questionnaire?
Yes.
So it's a fairly simple document. Dear donor, please write your donation number in the space below, and it explains what that is. Have you read the AIDS leaflet? If so, please tick the box. So that's a means.
That's the first box, yes.
And that's a means of trying to ensure that they're actually reading it and understanding what the risk categories are. And then if you think that you may be in a high-risk group as defined in the leaflet and you would still like to donate, please tick the box. In this case, we shall use your blood for research purposes only. So that's as it were, the face-saving get-out for the donor. They don't have to declare that they are gay or a drug user or anything of that kind. They just have to tick that. And the donation will be taken, but they'll know it won't be used other than for research.
And just so importantly that it was difficult at first with some of the staff to make them understand that we were not encouraging people in high-risk groups to come and give blood. What we wanted to do was encourage them to indicate to us that even though they'd come to give blood and they couldn't get out of giving blood, they didn't want their blood to be used, and that was so important.
And then can you just help me understand, because I found it slightly confusing, the capital letters then says only tick this second box if you are underlined in a high-risk group, but the question was if you think that you may be in a high-risk group. And those didn't seem to entirely marry up. Can you assist with that?
I'm afraid our questionnaires were not perfect. This is not the first version. The first version had a double negative in it, which obviously made it even less easy to understand. And, you know, I think we could have done better.
And then all information provided by you on this sheet will be kept strictly confidential. Finally, please fold this form and put it in the box provided. So that's the system. And have you got any recollection now of how many donations were not used as a result of the completion of this questionnaire, or either the completion of it or the completion of it in a way that led you to want to treat it as a positive?
It was even at the West End Donor Clinic, which we knew was our highest risk area. It was a very small number of donations, and with subsequent rollout to other clinics, it was less. But it was used, and donors appreciated it.
And would this be right that you'd have no real way of knowing how many people had not even got to the stage of coming to the sessions because of the overprinting of the call-up cards?
That's correct. That's correct.
Can we then just look at just 2 or 3 other documents in relation to this theme? NHBT 00194339. This is a memo from you dated the 14th of February 1985 to all MOs, so all medical officers. Following the discussion on AIDS at the MOs meeting, and just pausing there, was that a regular meeting that was held with all MOs?
Yes, I held regular meetings with the medical officers.
So concerned issues, themes, experiences from sessions could be fed back.
Because they were all working on, apart from the static clinic staff, they were all working individually with the mobile teams, and they didn't really see anybody else, any other medical staff. There had to be a forum for us to come together and discuss issues of concern, queries.
And then it says, we've decided that each donor should be asked individually whether he/she has read the AIDS leaflet. This will best be done by the member of staff responsible for performing the venipuncture, i.e. the medical officer on mobile teams, the nurses or medical officer at DBR and WEDC. If a donor has not read the leaflet, then one should be given at that point. This should start immediately. But is it right to understand that from this, that as at this point in time, mid-February 1985, in addition to the written materials being provided, there was now going to be the oral question asked, have you read the leaflet?
And I believe that was an instruction from the Department of Health.
So reflecting the rollout of the national leaflet, and we've looked at the circular in earlier hearings, but there was a request to try and ensure that it's brought to the attention of individual donors.
That's right, and
this was your way of doing it.
This is our way of doing it.
And then if we just look at NHBT 5030_013, please. This is a short article in the British Medical Journal in March of 1985, co-authored by you, Dr. Contreras, Dr. Barbara, and one of the scientific officers, Mr. McNutty.
Yes.
Blood donors at high risk of transmitting AIDS. I don't need to go through the detail of it. You describe under the heading in the second paragraph, subject, methods and results, what the system had been, and your introduction of the questionnaire in July 1984 at the West End Clinic. If we just go to the right-hand column, picking it up, fourth line down, donors in the high-risk category said that they had continued to donate despite the publicity about AIDS, because the original, if we can go to the text below the table, unrevised leaflet had implied that homosexuals with stable partnerships were still eligible as donors. And then, last paragraph, it's alarming that some male homosexuals still donate blood, and it is vital that all possible measures are taken to discourage this. So the study that you and your colleagues undertook, described in more detail in the text of this article, revealed an issue arising out of the text of the original leaflet.
Yes.
So someone who was in a stable gay relationship didn't think it applied to them because it referred to those essentially with a history of, or who were having multiple partners. Sexual relationships.
Yes, yes. And the reason we knew this was because each donor who used the questionnaire to indicate their blood should not be used was written to and asked to telephone to discuss their response in more detail. And then there was a telephone discussion with them in which we asked them, firstly, whether they had used it correctly, and secondly, why they had come to give blood. So we had this information from them by personal interview, if you like.
And then, could we look, please, now at a rather later document, September 1989, NHBT 0047637. No, you'll see from this, it's a memo from you to all MOs, 29th of September 1989. So we're now a number of years after the introduction, 4 years after the introduction of the testing of donations. But you said here, under the heading Blood Donors and HIV Risk, I'm very concerned that the last 2 cases of positive anti-HIV tests in donated blood arose because the written guidance on selection of donors was not applied. assessment of HIV risk is set out very clearly in the guidance for selection of donors. It's important that the guidance is followed, both to minimise the risk of infected but seronegative blood being inadvertently transfused and to reduce the possibility of testing being performed without adequate pre-test counselling on an individual recognised to be at significant risk of infection. HIV risk is one area where, if in doubt, defer must always be applied. I thought that this was already the case for all doctors. No clinic doctor should make an exception to the written guidance unless the particular case has been discussed with Dr. Moore or myself. And then you refer to the two cases in question. And one, a donor responded positively to the questionnaire, discussed her situation with the doctor despite the details which clearly classified her as a group 1 high risk. A donation was taken. And then two was one in which the donor revealed that they'd been in Africa, but there was no then further exploration with them as to where they'd been and when. Is that right?
Yep.
Now, is it right to understand from this, Dr. Hewitt, that although testing had been in place since 1985, donor selection remained an important additional tool?
No, I put it the other way around. Donor selection was the base, and testing was additional to the donor selection. Donor selection was always the most important, if you like. Testing, of course, produced a much greater level of certainty about the lack of infection, but donor selection is the base on which everything else follows.
And can I just explore with you whether there are two particular reasons why that remained important, notwithstanding the presence of the availability of testing? The first might be because there is what's I think known as the window period.
Yes, precisely.
And although that won't be a large number of cases, indeed it might be a very small number of cases, within that period of time the test won't pick up the signs of infection. Yes,
the tests we were using were all antibody-based tests, for HIV. And somebody who's been exposed to HIV infection will not develop antibodies the next day. There will be a period before the antibodies appear, and that is termed the window period. So there is a risk, and as you said, it was a very small risk, that somebody who might have been at risk of HIV infection could come along and give blood and be tested negative, but still actually have infection that would be capable of being transmitted to a recipient.
And would it be right to understand a second reason why donor selection remained very important, notwithstanding the availability of testing, might be because although you could test for HIV, there were other infections for which there were not national tests, and donors who are at high risk of HIV might also be at risk of transmitting other infections.
Yes.
So, for example, non-A, non-B hepatitis, or
yeah, absolutely,
because of drug use and
yes,
or other lifestyle issues.
Yes, we certainly did not want it to be thought that because we now had HIV testing, all the problems had gone away.
Now there are. Just want to ask you next just a handful of questions about what might be said to be particular groups of donors. We've been focusing on the process of individual donor selection and questioning. First group, prisons. Now we've heard from Professor Contreras and we've seen documentation to reflect that, but in relation to North London, the collection of donations from prisons had ceased by June 1972 because of the increased risk of hepatitis. And as I understand your evidence, that, as far as you're concerned, remained the position throughout the time you were there, other than prison staff?
Yes, that's correct. I am certain that we were holding at least one session in a prison, but it was purely for staff. There had been no blood collected from prisoners.
Now, the inquiry knows that other regional transfusion centres did continue in varying degrees and to varying extents to collect blood from prisons in the 1970s, and indeed through in the first half of the 1980s, and there are references to some centres ceasing the practice in perhaps late 1984. Does that surprise you?
From where I was, yes, it was very surprising. I was working in an environment where there had been quite a long tradition of taking account of infectious risks, and the director, but one before Professor Contreras, was Dr. Cleghorn, who was exceedingly foresighted. I mean, he was the individual who really understood that infection in relation to blood transfusion was a huge issue, and we were the only centre in England who had a consultant microbiologist, for instance, who had been appointed way before I was there because of the recognition of how important it was. So I grew up in the environment that why would you be collecting blood from what was recognised to be a population who were at much higher risk of infection? And back in the early 1970s, it was hepatitis B that was recognised to be that risk. And I was very surprised that it was continuing in so many places and for so long.
Second category, I wanted to ask you about military donors.
Yes.
Paul, could we have two documents side by side, because they're separate documents, but they're the first and second page of the same letter. So it's NHBT 0004776 and NHBT 0004777. If we can have them side by side, we can look at the whole letter. You try and get them side by side? If not, I can read one and then the other. Sorry, I thought it might simplify things, but I think I'm making life more difficult. Okay, we'll do it one by one. So this is the first page of the letter, Dr. Hewitt. I'm not quite sure, I'm afraid, why it's been split into two separate documents. 9th of July 1992, you're writing to Dr. Gunson, donor sessions in US military establishments. For many years until 1986, we held regular blood donor sessions at a US military establishment in Bedfordshire. This was the only US establishment served by NLBTC, but the donor session also served a number of UK civilian personnel. And then you go on in this paragraph to explain how that came to an end. Without going through the entire letter, I'm going to paraphrase. You or your colleagues learnt in late 1985, early 1986, that there was an expectation that the results of the routine screening test would be notified to the US military authorities. So you'd be expected not just to tell the donor confidentially that their donation had tested HTLV3 positive, but to pass that on to the military authorities at a time when being gay in the US military was illegal.
That wasn't the issue. The issue was that we told donors that their information would remain confidential.
And so if we just look back at the rest of the page, you say in the last paragraph on that page, I understand the RTDs agreed collectively in 1986 that they could not agree to the US military's request, as in this country all test results are confidential and reported to the donor alone. And then there's reference to a compromise being proposed. But then you go on to say your next donor session at the particular base that the North London Transfusion Centre served was cancelled and there were no further sessions. And then if we just go to the next page, just to see the broader context of the letter. Oh yes, 477. You say in the first paragraph, we've never identified any US military personnel who may donate at other sessions held within our area We are responsible for a number of UK military establishments, and some of these probably have donors from the US forces. I don't know what the situation is with regard to these donors. And then you go on to raise the question of whether donor blood sessions could be re-established at the US base. Now, can you recall whether any express consideration was given in the period from 1984 to early 1986, when collection from the US base came to an end, of the possibility that military donors might be at higher risk?
No, I don't recall any discussions about that at all.
Or any discussion about the possibility that military donors might not be truly voluntary?
No, I don't recall any discussions about that.
Would it be fair to say that military donors might have good reason to be reticent about disclosing information, for example, regarding drug use or gay sex?
I could imagine that would be the situation in other situations as well, but I feel that because our donors were completing a confidential unit exclusion questionnaire, I felt that that was possibly less of an issue for our sessions.
Other than the US base at which you held a donor session, were there also UK military establishments from where you held donor sessions?
Yes, and since I heard Dr. Entwistle's evidence, I've been racking my brains to think about that. I can remember one or two RAF bases. We definitely held sessions at the RAF base near to Harefield Hospital, which was often called on by Professor Yacoub for donations. There were probably one or two other RAF bases. I don't remember any Army sessions, and that may be because the Army Blood Supply Depot in Aldershot held its own collection sessions, which may well have tipped over into our area. And for obvious reasons, I don't think we had any naval bases. But we also, we did actually, I probably still do, hold collection sessions at the Ministry of Defence.
But I'm right to understand then from your earlier answers that you don't recall any express consideration being given at the time to the possibility of whether military donations represented any particular
I don't recall
risks.
any discussions about that, no.
And then the third category, which we've already touched on, was IVD use, intravenous drug use. What measures were in place, other than through the terms of the AIDS leaflets, to prevent those with a history of IVDU giving blood? You've got the obvious track marks that might be identified by a doctor.
I can't recall anything else, no.
Do you recall whether any consideration was ever given to expressly formulating leaflets directed at those who might have used intravenous drugs?
No.
Because it just as you've described from the survey on the questionnaire from gay donors, they might have, some may have misunderstood and thought, well, this doesn't apply to me because I'm in a stable relationship, I'm not having a relationship with multiple partners. Would you accept there might be a possibility that those who had used drugs once or twice in the past, some years before, might think the way in which the leaflet was phrased didn't really apply to them because they weren't active on drug users?
Certainly, you see that first leaflet talked about drug addicts. Yeah. When we started screening blood for HCV infection and we interviewed donors who we did find to be hepatitis C positive, we had a number of donors who, on sympathetic questioning, revealed a history of intravenous drug use on one or two occasions. And none of those people would consider themselves drug addicts or even intravenous drug users, because it was something they'd done in the past which they felt either they'd completely forgotten about or they had suppressed the information, and they certainly didn't consider that they were drug users.
So in hindsight, would it have been a good idea to have some kind of leaflet or literature information that spelt out the position more clearly in relation to those who might have used drugs in the past?
Well, I think the wording was all important, and the wording wasn't right.
Now, it's apparent from the evidence you've given, Dr. Hewitt, that at the North London Centre, there were a number of proactive initiatives in relation to donor selection that the centre introduced that went beyond the national measures. We've got the questionnaire, we've got the additional leaflet, we've got the overwriting of both the leaflet and the call-up cards, and the cessation of prison donations from the early 1970s. It may be, of course, that there were other individual regional transfusion centres who had their own initiatives. Is it right to understand that other than through the regional transfusion directors' meetings, there was, because of the way in which the blood transfusion service was organised, there was no means of ensuring that every centre took the best practice at individual centres and applied it across the board?
Yeah, absolutely.
And so a proper national blood transfusion service, an organisation such as was then created in due course in the 1990s, if that had been in existence in the 1970s, 1980s, might have been a means of ensuring that these kind of local initiatives that helped reduce risk could have been introduced nationally.
Absolutely. I think the first thing that would happen was said, right, North London, you do a pilot study, and then let's look at it, and then it should go out wider.
Can I come then to the question of the introduction of the AIDS screening tests in the autumn of 1985? As I understand it, Dr. Hewitt, you weren't involved in decision-making about the introduction of the screening tests and when they should be introduced.
That's correct.
Did you understand that, however, if you had any particular thoughts about it at the time, to be a decision for the Department of Health or a decision for regional transfusion centres?
I don't think I knew at the time whose decision it was.
Now, when testing was introduced in October 1985, or I think at North London, a little earlier, 23rd of September 1985, what were the arrangements that were then put in place? How was it managed? From your perspective,
From my
in terms
perspective,
of the role
yes.
that you performed.
So my role was to manage not negative test results, and not with respect to what happened to the donations, because the donations just were discarded, but in relation to the donors whose blood samples had given not negative test results. So with respect to donors who had been confirmed positive for HIV infection, and that confirmation was made by a reference laboratory, so the samples would be sent to a reference laboratory, and the reference laboratory would issue a written report. And once I had received a written report confirming HIV positivity, then a letter would be sent to the donor, which was a very short and very bland letter, just words to the effect that we'd like to talk to you about your recent blood donation. It may have said something about one of the results. I think it was an unexpected result, which was true. We didn't expect to get positive results. Please contact us to arrange an appointment to be seen. So that letter would be sent to the donor. It was always sent, signed by me, and it was sent to arrive early in the week, because we didn't want letters to arrive on a Friday and then find that the donor got home from work on Friday night and worried over the weekend about what they should be doing. And when they telephoned, it was a dedicated number to our office, if you like. So the staff who dealt with the phone call would be expecting the phone call, and then they would arrange for the donor to attend an appointment to be seen by myself or my colleague. And the two of us had been on an HIV counselling training course run by St Mary's Hospital to prepare the staff at blood centres who would be dealing with donors with confirmed positive test results. And as you're aware, I dislike the term counselling because I never was a trained counsellor. But that was, in theory, what we'd been trained for, to communicate the test results. So the donor would attend for the appointment, saw the donor in private, alone, and explained that they had a positive test for HIV. Now, obviously, over the years, the content of the discussion would change. In the very early days, it was one of the first things was to understand that doesn't mean you've got AIDS, to try and explain what the test indicated. But also in the early days, we didn't really know what a positive test indicated from the point of view of that individual and the prognosis. But I think pretty soon it became clear that we really needed to impress upon that individual that a positive test implied that they had been infected with HIV and they remained infected with HIV, and it could lead to illness. We would discuss with the donor what that meant for them and their individual situation, how they responded to that information, what questions they had, who they might want to tell, who they should tell, who they shouldn't tell, what should happen next from the point of view that all our donors were referred to a specialist centre. We carried out the referral. We discussed with them where would be appropriate for them to go. Not everybody wanted to go to their local centre for various reasons. We had set up very good relationships with two of the biggest HIV centres in London. So that was St Mary's Hospital in Paddington and the Middlesex Hospital. And that initially covered quite the right areas for the donors we were detecting as positive. And the majority of donors were men who had sex with men, which those clinics specialised in. But we had a number of female donors, and it was often inappropriate to send them to those environments. And we had another special relationship with the HIV unit at the Royal Free Hospital, which ran a clinic for females with HIV. So our female donors would generally be directed there. And in the early days, those were the only referral centres we used. But as HIV infection became more spread geographically, we then developed relationships with most of the units in our area. So we would agree with the donor where they wanted to be referred. We would explain to them the importance of going to a specialist clinic, even though in the early days there was no treatment available for HIV, but that unless they were known at a specialist centre, they would possibly miss out on things that would be developing. And we would, in the early days, we would take a second blood sample, and that was it. We stressed to the donors that was not because we doubted the results of the first sample. They had been confirmed. We knew that our procedures were safe and that there should not be any question of a wrong identity, but that we wanted the donor to be certain that the result belonged to them. So if they saw us take a blood sample from them, then they could be assured that it was their blood. We arranged to test that sample within our own microbiology laboratory by a rapid test, so we would have the result within 24 hours. We agreed with the donor we always spoke to them afterwards by telephone with that result. Actually, looking back, in the early days, we arranged to see the donor a second time after about a week. And that's when we would have given them the result of the second test and gone into more detail. But as time went on, it became clear that wasn't really the best way to manage it for the donor's point of view, because they needed to get onto a specialist centre where they could have further investigations and counselling, proper counselling. So at some point, and I can't remember when, we dropped the second visit. So we would give the result of the repeat blood test over the telephone the next day. and we would confirm the arrangements for their attendance at the specialist clinic, which we arranged for them by personal contact with the specialist centre.
So in terms of the referral to the specialist clinic, that they didn't have to go back to their GP for that. You would do it directly?
We did not communicate with the GPs at all. We emphasised to donors that these results were confidential, and we had not spoken to anybody else about them, but we would speak to the specialist clinic. We impressed upon them the importance of their GP being aware of the information, because if the GP was not aware and the donor went to visit for something apparently unrelated, it might actually be related, but if the GP didn't know about the HIV, then that might not make a connection. But in the very early days, the HIV tended to be only dealt with in the specialist centres, and GPs were not involved at all, and most donors didn't want their GPs to be involved. So we made a direct referral to the specialist centre. We would telephone the specialist centre. We would agree an appointment. We would then write a letter to the specialist centre setting out some of the background that we'd established with the donor, so that when the donor attended the specialist centre, they had some knowledge, the centre had some knowledge about the donor and any particular issues which had arisen during our interview with the donor. And we would then speak to the donor and say, this is your appointment. If there's a problem, let us know and we can rearrange it.
And then just going back to the issue about the testing, the initial testing of the donations, that would have been done in your microbiology lab at the centre?
Yes.
And if the test showed positive, or there was something about it that wasn't clearly negative, put it that way, you've explained it would be sent off for confirmatory testing.
Yes.
That was undertaken at one of the reference laboratories.
Yes.
And it's only after that that the donor would be contacted?
It was only once we had the written report. Even a telephone message, it was a written report from the reference centre.
And can you recall, at least in the early weeks and months, what the kind of time gap was between the initial test result in your microbiology lab and how long it might take to get the written report from the reference lab?
It could be a week or 10 days, I think.
And then just to understand your rejection of the term counselling, I think essentially for the same reasons as Dr. Williamson yesterday.
I've trained Dr. Williamson well.
So you were not offering counselling in the sense that the inquiry has often talked about it,
yes.
talked about its absence, some form of ongoing psychological support. The term counselling that we see referred to in the documentation at this time is describing the communication of the test result and its implications.
Yes, and I spent a long time battling against the counselling word. I subsequently changed the title to post-test discussion, because that much more accurately reflected what we were doing.
And as you described, that might be it might have been two discussions, and then over a period of time it became one discussion, yes. Because the baton was then essentially picked up by the specialist service. Yes. I'll come back to HIV in the context of the look back this afternoon when I ask you some questions about look back more generally. What I want to do now is just turn to a different aspect of your evidence. And in your look-back witness statement, you've set out for us a narrative by reference to some older documents from the 1940s onwards, showing the importance of following up, recording and following up jaundice and hepatitis.
Yep.
And what I just want to do in the 10 minutes or so before lunch is just pick up on a handful of those documents with you, just to understand what they are, and because they're important materials that we haven't looked at in previous inquiry hearings. But as I understand it, you're really doing no more than putting them before the inquiry, because obviously you weren't around the time of the discussions that they referred to. So if we start with DHSC 01508_192, please. And you've given a much more detailed account of the documents, or summary of the documents in your statement, Dr. Hewitt. As I say, I'm only going to go to a handful of them and pick up on some of the themes that we've talked about already. So this is some advice given in August of 1946. You've set out the context of it in your statement and some of the earlier communications. It explains in the first paragraph, I gather the question of liability, and the concern was about the liability of medical officers within the blood transfusion service, may arise in two ways. A, where plasma is issued by the blood transfusion service to a hospital to be used by the hospital's own staff. B, where plasma is given to a patient either by a medical officer of the blood transfusion service or a medical officer of the hospital. Sorry, just pausing there. You've explained in your statement that the reference to plasma here is a reference to something different from plasma as we talk about it in the 1980s through plasmapheresis. So I think the context of this debate was a debate between using whole blood and using a particular component described in this material as plasma.
Yes.
And then it says, it seems to me that it will be difficult to make the BTS liable if A, they give full warning of the potential dangers, B, take all reasonable steps to withdraw or destroy any batch which they know or ought reasonably to know is particularly dangerous. And then it continues, it seems therefore desirable that the BTS should take steps to have the batch number of plasma recorded at the time of use and to be informed immediately if any case of jaundice develops so that action could be taken to avoid any further use of that batch. Whether such a course is reasonably practicable is a question which I cannot express any opinion. On B, I think that a medical officer who gave plasma to a patient would not be liable for any jaundice which developed if, after full consideration of the relative risks involved, he honestly and reasonably decided that the risk was worth running in the circumstances and took all reasonable steps to reduce the risk to the lowest possible level. And then over the page, just so that we can see the date, it talks about the general principles can't cover all cases, and it's signed by a particular solicitor, August 1946. If we just go back to the first page, just want to explore with you the extent to which this is an early indication of perhaps four themes that we've touched on in the course of your evidence, and we'll come back to when we look back this afternoon. First of all, the importance of record keeping. Mm-hmm. So we can see that being emphasised as early as the 1940s.
Yep.
Secondly, the importance of the reporting of jaundice so that investigations can be undertaken by the blood transfusion service.
Yes.
Thirdly, as a general statement, the importance of the blood transfusion service taking all reasonable steps to reduce risk, and we explored earlier the ways in which that might happen. And then fourthly, the importance of patients being given full warning of potential dangers and taking their own decision balancing risks. And I think you observe in your statement, by reference to these documents, that will generally fall to the treating clinician rather than the blood transfusion service directly.
Yes.
And then if we just pick up...
Yes, I think the way in which you put the question was the patient's being given full warning of the potential risks. That's not the case here, is it? This is the doctor.
Yes.
It's the doctor
so you're absolutely right.
Who's drawing the
yes.
balance, making the balance.
You're absolutely right. In fact, I'd read that wrongly, perhaps through modern eyes rather than the eyes of the 1940s.
And this is the paternal...
The paternalistic approach.
Yeah.
Yeah, the doctor. And I think picking up...
And I think it may be because the document is looking at the solicitor is looking at the liability of the blood transfusion service, not at the liability of the doctor. If it came to the liability of the doctor, there may be other considerations.
Yes, so no, absolutely right. So if we try and translate that, however, into modern practice, and by modern I'm talking about the 1980s onwards, the patient being informed by the treating clinician of the risks of transfusion, which might include the risks of transfusion transmitted infection, would be an integral part of ensuring overall the safety of the supply of blood. And then if we just look at, just in terms of the importance of record keeping, DHSC 1609_066 Do you need that again, Paul? DHSC 4009_066. No? Well, what I'll just read the relevant passage and then just ask you the one question I have about it. So it's one of a number of the historical documents you've drawn attention to in your witness statement by way of contextualising the process of look back, I think. And this happens to be a letter from Dr. Maycock to the British Medical Journal, I think probably to the editor or to a Dr. Clegg at the British Medical Journal, 21st of October 1947. And I'll just read two passages from it. First paragraph, there still seems to be a large number of doctors who do not appreciate that both plasma and serum carry a risk of homologous serum jaundice and that this disease is rather more than a transfusion reaction. And then the last paragraph, which is the third paragraph of the letter, says, I've been told by the regional transfusion officer at Bristol that descriptions of 3 cases of homologous serum jaundice are being submitted to you for publication in the BMJ. And I wondered whether you would consider this an appropriate time for a leader or annotation on the disease, stressing the practical importance of such small points as recording batch number. So would it be right to understand that this and a number of the other documents you've referred to from this time in your statement are an early emphasis of the importance of record keeping in relation to reducing the risks of transmission of infections such as hepatitis?
Yes, indeed.
We've got the document on screen now in any event.
I'm curious about this because I think it was the 4th of October that there was an article, this is RNIT 5054, which was entitled Homologous Serum Jaundice in Recipients of Pooled Plasma, which included the words that plasma, as well as other forms of transfusion therapy, should be administered only when the clinical indications are absolute, so the benefits to be derived clearly outweigh the risk of contracting homologous serum jaundice. So it's the same message, but it was just earlier that month there had been actually an article. I haven't made a note, I'm afraid, of where the article was actually published. It may not have been the BMJ.
No, and we can check that. But in any event, it appears that these very themes that we've been exploring are really at the forefront of the blood transfusion services mind back in the 1940s.
Yes, and I think Professor Maycock, a year or so earlier, had actually described to a doctor, an individual GP, plasma as being a potentially lethal fluid.
Yes.
Which should be used with discretion. So it's exactly the same message.
So I note the time, so perhaps we could break at this point and pick matters up at 2.
Yes. Very well, 2 o'clock. 2 o'clock.